Hello, everybody. I'm Talati. I'm one of the acute myeloid leukemia and high-risk MDS clinicians here at Moffitt Cancer Center in Tampa, Florida. And I wanted to give my opinion today on how COVID-19 pandemic has impacted our overall treatment for our patients with acute myeloid leukemia. As many of you already know, acute myeloid leukemia is still considered a little bit of an urgent diagnosis. In most cases, we do require initiation of treatment in a timely manner. And there has been, several discussions and controversies in regards to how should we induce these patients? Is induction chemotherapy, is that still the right thing to do? Or should we move forward with outpatient therapy with, availability of hypomethylating agents, specifically azacitidine or venetoclax? When the COVID-19 initially, was going on, we had, no more information about COVID-19, there was a lot of panic about this, as we all are still in the same situation, but we do understand the disease a little bit better, I would say, at this time. With the availability of vaccines and whatnot, I think we are kind of seeing light, hopefully, at the end of the tunnel, although we have a long way to go, we all realize that. But in terms of our acute myeloid leukemia patients, we still consider induction chemotherapy in a pre-pandemic era if the patient was deemed eligible for intensive chemotherapy. At this time, we still induce our patients with induction chemotherapy because that, for some of these patients, such as favorable risk or intermediate risk, this has the best outcomes. So, our remission therapy still is induction chemotherapy. In terms of, for our relatively frail patients, outpatient therapy with hypomethylating agent and venetoclax can be considered. Although a lot of these patients, they require transfusions fairly frequently, as all of our acute myeloid leukemia patients. And therefore, doing televisits is an option. The world has changed in terms of telemedicine versus in-person visits. However, because of the transfusion burden and requirement, doing telemedicine may not be the most optimal for these patients, as they would still need to come and get their transfusions in the transfusion unit. So when I consider how am I going to treat my patient with, induction chemotherapy versus lower intensity therapy, the way I think about it is, number one, are they still eligible to receive intensive chemotherapy? And is that the right treatment for the patient given the disease characteristics? And if answer to both of them are yes, I would proceed with induction chemotherapy. Now, if there is an older patient or a frail patient, or the disease characteristics are more suggestive that they have lower responses to induction chemotherapy, then we would proceed with a hypomethylating agent plus minus venetoclax as a treatment option. One thing that has changed since the COVID-19 pandemic hit is that we are testing all of our patients before we start therapy, either with induction or the lower intensity. Let's say a patient gets a COVID-19 test. We wait, and it has to be done within 7 days. That's kind of our institutional standard at this time. And as long as they are negative, there are no additional risks, and we move forward with the induction chemotherapy. If the test does come back positive and we are unable to wait for, about 14 days or so for treatment initiation, and if we have to proceed for whatever reason, such as proliferative disease, patients in DIC, etc., early high mortality risk, then, we have to have that discussion with the patient, and then we would still proceed with the induction chemotherapy if that's the right thing to do. Also, having discussion about the hypomethylating agent and venetoclax is appropriate for that patient in conjunction with the family support as well. Another way this has impacted our patients a lot is the visitation. A lot of these patients who are going through the induction chemotherapy, initially visitations were extremely limited in terms of which family member can come. Initially, we had no visitors allowed at all unless patient was making end-of-life decision. And at that time, the family member was allowed for a few hours, etc., we have come a long way since then. And now, we are allowing patients with limited hours, of visitation from the family member member, one member at a time, etc. There are still a lot of limitations in that regard, which makes it very tough for our patients who are undergoing intensive chemotherapy. And again, all of this discussion up front with the patient, what are the expectations, how this is going to go, is extremely important. One other point that I would like to make is that the transfusions, there has been somewhat of a scarcity depending on the geographic area about the donors for blood product donations. And that has become, and that has put strain on, how much can we transfuse our patients. And, that may impact patients' decisions about the type of therapy, targeted agents, outpatient approaches may be more amenable for those patients. And we are a little bit strict on, the transfusion parameters as far as hemoglobin level, less than 7, platelets less than 10, etc. So, it is a very different world that we are living in. And, in terms of vaccinations, we are advising all of our patients, if they are able to get vaccinated. And we have started doing vaccinations for a while at our institution as well. I truly believe that these patients are immunocompromised, and they should, and therefore they should receive a vaccine. Now, that's a general statement. However, everything is case dependent. For patients that are, undergoing bone marrow stem cell transplant, for example, it doesn't make sense for them to be vaccinated because they are not going to mount the response, and whatever response they mount will be eradicated with the transplant process. So, it's a case by case basis, but I think it's a discussion and individual discussion that needs to happen with each patient.